Okay, it should be recording now. So hello again, everyone. Welcome to Brain B. So I just want to first talk a little bit about what Brain B is going to be like this year. So this year's Brain B will be hosted on February 26th in the afternoon. So in preparation of the Brain B, we have 3 Saturday tutorials. So we had one 2 weeks ago. You're now in the second one. And next Saturday, we'll have another one. Don't worry about the exact logistics. We'll be sending out email reminders to give you the time and Zoom links. What is new this year is because we're doing everything asynchronously, we thought it's important for students to interact with the material. So we have prepared these neuroscience at home toolkits that involve, fun gadgets, handout, and crosswords that allow you to, really interact and explore through the material. We'll be using the last tutorial, which is next Saturday, to walk you through the toolkits. However, we'll also be posting instructional videos on YouTube so that you can go through them at your own pace. During the day of the B, so we'll begin with some fun icebreakers where you can connect to college students, and then we'll talk about some fun interactive demos. We used to do this brain anatomy tour where we bring in real brain specimen and you can touch it and you can observe it from different angles. And then we'll have a trivia style written quiz and oral competition, very similar to a spelling bee or to Jeopardy! We'll wrap up the day with neuroscientists and physician speaker panel. You'll get a glimpse into their career, what's their growth since college, how did they get to what they're doing now, what's the typical day in their life. And lastly, I want to emphasize this year we'll be giving out amazing prizes. I believe the top 10 contestants will receive gift cards that apply to a lot of places. And then we'll also be giving out trophies, ceremonial t-shirts, and I believe the top person to win the B will receive a trip to the nationals, and then we'll also get funded for a summer research experience. But overall, you have so much to gain from the Brain B, so we really encourage you to participate. All activities are free, but we do require you to register at this website. So I'll also be sending out an email reminder for that. I believe a lot of you have already registered, so you don't have to do anything on your part, but if you haven't, please just make sure to register. This is the best way for us to, to have your email on file so we can make sure that you're up to date for all the relevant information. And briefly, I'll talk about study materials. So really, we want Brain B to be a fun event rather than like a competition or a quiz. We know that, as students, you already have so much on your plates, and we don't want to overburden you with that. That being said, it's important to have some fundamentals about neuroscience, and that's why we're doing all of these tutorials. In the last tutorial, we talk about the structure of the brain. We talk about the structure of the neuron. How do they work? How do they communicate with each other to support bodily functions? In support of that, there is an amazing little guidebook called Brain Facts. This is where all of the questions of the Brain B will be deriving from. It's a fairly short book with very digestible chapters. I think each chapter is like 5 to 7 pages. They talk about really the groundwork of neuroscience. Also, if you go to brainfacts.org, you can see there's a 3D brain model that you can really, twist around at different angles to observe the brain. And lastly, as I was talking about, we have neuroscience like home toolkits to come very soon. So regarding the kits, what do we actually include in those kits? Well, first of all, we have a brain stress ball model that really resembles a real brain. You can take that home, save it as like a real stress ball and just as a souvenir. We'll also be including visual illusion cards, and those are just really cool. We'll also be including a somatosensation experiment setup. So we'll provide you with everything that you need for the experiment. You'll be able to experience what it's like to, first to design an experiment, collect your data, analyze your data, and derive conclusion. Lastly, we have amazing handouts and crosswords for you to do. So again, the importance to register is that you can receive your kits for free. When you register, we ask you to put in your school contact information. That includes your school address. So we will, by default, ship these kits to your school. However, we also offer the option to ship to an alternate address, such as your home address. And this coming Friday at Washington University, if you happen to be in the St. Louis area, we offer a 2-hour self-pickup window. So the important thing, again, is just to register. We'll be sending out emails to your registered email about all of these information and about how you can update your address in the system. Okay, are there any questions about logistics? Awesome. If you have, again, if you have questions, feel free to shout them out or put them in the chat, either to everyone or to Jane. Okay, without further ado, let's get started with this tutorial. So welcome everyone. My name is Adrian Lee. Today I'm joined by two amazing volunteers, Neil and Jane. Would you like to introduce yourselves?
Jane, would you like to go first?
Yeah, sure. Hi everyone, I'm Jane. I'm a freshman at WashU, and I'm planning on studying biology with neuroscience.
Awesome. Hey everyone, my name is Neil. I'm like Adrian, I'm a senior at WashU and on the pre-med track applying to med school currently. So yeah.
Sounds good. I'll also briefly introduce myself because I forgot to do that. So my name is Adrian. I am a senior here at WashU. I study cognitive neuroscience, so really about how people think and how the brain system supports thinking. I also study chemistry, and you will see that we will be talking about some neurotransmitters that might be pertinent to that. I've been involved in Synapse and education for really about 4 years now, and I've been involved in 3 past Brain Bees. So I know really the ins and outs of the competition. Okay, so we'll just be beginning with our content review. So again, these content review are supposed to give you like a foundational understanding about various topics that will be covered by the Brain Bee. We really try to supplement our content with a lot of like multimedia, with news articles, with videos to really show you like how neuroscience is applied to real life scenarios. So the first part we'll be talking about will be developmental and psychiatric conditions. So we'll begin by some developmental conditions. The first one I want to talk about is autism spectrum disorders. A lot of, we know them as ASD or simply autism. So really in autism spectrum disorders, people typically experience impaired social skills. There will be more like introversion in layman's terms. There will be verbal or nonverbal communication issues, verbal being normal language, nonverbal being more like bodily languages. And then people with ASD also typically develop narrow or obsessive interests or repetitive behaviors. So here, if you look at this infographic, again, you see inability to use spoken language. ASD, people with ASD tend to be very sensitive to external stimuli. They get very uncomfortable when there's large crowds speaking or like bright lights. Really, they're sensitive to their environment. They sometimes have lower IQ. However, this is not always true. There is a kind of like a subtype, but now it's more separated type of ASD that is called Asperger's, where lower IQ is actually not true. ASD also involves repetitive behaviors like violent rocking or door slamming. A lot of them seem to be very compulsive, so they're just repeating them without like a specific intention or reason. And lastly, people with ASD sometimes have physical symptoms like sleepiness, or we call them hypersomnia. Sometimes they have epilepsy as well. And we'll later talk about what epilepsy really is. I think what's really important is to focus on the word spectrum. So they used to be only called autism, but then people realized that there is really this diverse collection of symptoms people can manifest. Not everyone with ASD have all of these symptoms. And you can see there can be different levels of ASD reflecting different levels of severity. So really, when we talk about all of these developmental and psychiatric conditions, we want to be focusing on a spectrum, right? They're like all continuous. They're not just discrete. And this really, speaks a problem in our current day diagnosis because you have to pass a certain threshold to be considered to have a condition. Though, scientifically, that's not how it works, right? Because we have this continuum of symptoms. So you may land maybe just a little bit below the threshold, but you will still be considered at risk for a condition. And next, I want to talk about ADHD, or attention deficit / hyperactivity disorder. So this is a very common condition, especially around young kids and adolescents. This is characterized by excessively inattentive or hyperactive or impulsive behaviors. So these behaviors may not manifest at the same time. So some people may just have, really low attentional span, meaning that they will pay attention to something, but then they will quickly get distracted. Or sometimes people are hyperactive, and you can see them in their body language, like they might have jerky movements. They may be compulsively doing something repetitively. Again, this is very prevalent, affects about 11% of school-age kids. What's really alarming is that 30% of these kids will continue to experience symptoms into adulthood. So we're not entirely sure how ADHD develops. People have said it's a neurologic symptom, but there seems to be a lot of genetic contributions to it. So researchers have recently developed VR, or virtual reality therapy, to help these kids to really orient themselves in a classroom setting and to inhibit their attentional deficits. So I'm just going to show you this short clip.
For ADHD, it impairs one's ability to get their work done. It really interferes with their ability to listen to the teacher in the classroom or do their homework. So what we really need to do is learn to teach people to learn to ignore distractions. So teach them to learn to enhance their attention. And medications don't do that. And I started thinking, well, why couldn't we do that with virtual reality?
Okay, you ready?
Yeah.
All right, here we go.
So what we've created is a virtual classroom. So they're sitting in a classroom and they look around and there's children behind them and there's children in front of them. And every once in a while they're doing the math test or these other attention kinds of tests, there's a child leaning over and talking to another one, which can be very distracting. Another child might drop their pencil. Typical distractions one might encounter in a classroom. So the idea is that while they're doing their work, they can also be exposed to these distractions and learn to ignore them.
I probably got a few answers wrong because of it, but not that many.
So at this point, what the therapy entails is that they come for a practice session here, and we're using eye tracking so we can gauge whether or not they're distracted. Then they take home with them, they take a virtual reality headset and a cell phone that we give them, and they're instructed to practice about 20 minutes a day for about 25 sessions. Ultimately, we want to assess whether this changes their behavior in the classroom or at home. So we're also taking rating scale measures because that's the beauty of virtual reality, is that it should transfer to real settings. And so we want to assess whether there actually is a change in the real setting.
Yeah, so quickly to recap, you can see them wearing these VR headsets in which, these kids will be actually seeing like a simulated environment of a classroom, and then the researchers will introduce some distractions, right? And they're really training these kids to first get familiar with these distractions, and then later to really not focus on those distractions. So this is one way that is shown to be really effective in treating ADHD. Do I have questions? Okay.
Nothing in the chat. I don't know if anyone wants to shout anything out.
Sounds good. All right. The next developmental condition is a little bit different because this one has a very clear genetic background. We know exactly why it happens, and this is called Down syndrome. This syndrome involves a very well-known chromosomal abnormality. So if you look at here, now in healthy people, we have 22 pairs of chromosomes, right? You can see for chromosome 1, you have a pair. Chromosome 2, you have a pair. And then in healthy people, you will have 22 pairs, meaning you have 44 chromosomes plus the sex chromosome, right? If you are male, you would have XY. If you're female, you have XX. However, in people with Down syndrome, they have one additional replicate of the 21st chromosome. So this is what we call trisomy 21. And this is the genetic cause behind Down syndrome. This is fairly common. We have more than 250K cases in the United States. These kids typically develop skills at a slower rate than average. By skills, we mean like walking, talking, sitting, toilet training. So you really see some of these manifestations early on in development, usually when they're still little babies. Physical signs are also very clear, including like low muscle tone. So muscle tone is basically, we always have some pressure in our muscle that allows us movement, right? But if you have low muscle tone, your muscle may be dangling, especially in your facial area. People with Down syndrome also typically have upward slant to eyes. So their eyes look a little bit different. They have a more flat facial profile and they have enlarged tongue. So a lot of us really may have family members or friends or people that we know are impacted by Down syndrome. And this really reflects how prevalent it is. This condition, unfortunately, is also associated with mild and moderate intellectual disabilities. So Down syndrome is considered a disability, and there are social resources to support people with Down syndrome. And there is a lot of research, especially here at WashU, that are underway to really help us address some of these symptoms within Down syndrome. Okay, and lastly, I want to talk about dyslexia. So dyslexia is about this unexpected difficulty in speaking and reading, especially in kids, but we also see them in adults who otherwise are completely healthy. So they have normal intelligence, they have normal motivation. So this is not like some sort of psychiatric condition. They receive the same amount of education. A lot of them turn out to be very successful in their career. However, when they are reading or writing sometimes, they'll have difficulty where they will appear to be slower. This is a very persistent and chronic, meaning long-term condition. And really people with dyslexia has very low reading rate. So I remember so do you guys know Percy Jackson? So Percy Jackson, the famous character in the novel, actually has dyslexia, and he described it as seeing all of those letters kind of like shifting around and just randomizing, just jumbling around, right? So this is very common in people with dyslexia. Okay, so without further ado, we've talked about 4 developmental conditions, and I want to test you a little bit. So I'll be giving you little cases in which I want you to identify what the condition really is. Okay, let's see. So this is the first case study. So remember, we talk about autism or autism spectrum disorders. We have ADHD, attentional deficit or hyperactivity. We have Down syndrome and then dyslexia. So in this case, we have a young girl presenting to the clinic. Imagine you're a doctor. So Grace has problem with visual scanning, processing, memory. She also has issues with spelling and problem solving. However, she's very strong in terms of verbal skills and she's artistic. She learns well with color. Okay, so Grace's issues are really with spelling and visual scanning, right? And unfortunately, Grace's teacher will think that she's too slow, that she's not putting enough effort. And Grace struggle with numerical operations and story problems. So out of these 4 conditions, which one, so this is what we call differential diagnosis if you're an actual doctor. So which one is her most likely differential? Okay, and I see someone put something in chat, Adriana and Studi. Dyslexia. And you'll be correct. So the answer is dyslexia. And why? Well, because we know that people with dyslexia are otherwise fully, healthy. They have normal intelligence. They have normal education levels. And you can see clearly Grace is very strong in verbal skills and she's very artistic, meaning that she is developmentally healthy. However, her biggest issue and probably her only issue is with reading, and that created a lot of like collateral problems. So from this case, I want to highlight 2 issues that the society really has. So one is that there might be a lot of, social or what we call socioeconomic pressure on people with these kind of development conditions. A lot of them tend to be, very demanding, such as you're not performing so well in school. Maybe you're not just putting in enough effort, where in reality, there might be a developmental condition. And for physicians, it's important to dissect, to really look past all of these socioeconomic variables to really get into the nature of the condition. Another thing I want to note is really look at how diagnosis is based on so many factors, right? So we might have parents giving reports. We have symptoms the kid is displaying. We have family and community and teachers telling us how the kid is performing. And lastly, we have clinical assessments. So really in everyday diagnosis of these conditions, you would need to draw inputs from various avenues. Okay, so here we have another case. So Anderson was a full-term baby, no complications. That means there's no health concerns. And his development seems to be fairly normal, right? He hit major milestones of sitting, standing, and walking. However, at age 3, he was described as low tone, and he has awkward motor skills, and he's inconsistent with imitation skills. So imitation is basically where the parents do something, and then developmentally, the kids will start to follow them. Anderson's communication was delayed, and unfortunately had no word development by 3 years. Importantly, I want to know that genetic testing suggested no chromosomal abnormality. So in this case, you can almost just rule out one of these cases. So what do we think about this case? Okay.
I was thinking people are saying autism in the chat if you can't see that. So.
Awesome. Thank you, Jane. Yes, so the answer would be autism. So first of all, the hint is no chromosomal abnormality. So you should be ruling out Down syndrome because in Down syndrome, we have one extra copy of chromosome 21. So really the case here is really autism, right? The word development is delayed. We have some motor skills that are inconsistent with normal development. Perfect. Oh, I need to move this around. Okay, next case study. So we have Sam here. Sam has some problematic behavior that is believed to interfere with classwork. So what does he do? Well, he refuses to respond to the teacher. He throws some tantrum, throws materials, avoids activities. He is also engaged in behavior that took the form of tongue protrusion, while at the same time making a clicking sound. So this behavior is stigmatizing, disruptive, and Sam also took a long time to learn how to sit, walk, and toilet train. So I see some people have responded in the chat. Okay, so we have many people telling us it's ADHD. So really the case here is actually Down syndrome. Now this can be tricky because for Down syndrome, you would almost always want chromosomal testing, right? But it might not be the first thing you look for. If you have just a new patient coming in and they're telling you they have all these issues, you're really just assessing their clinical symptoms, right? It's very rare for a patient to just come in and say, hey, here are my chromosomes, right? I already know what my results are. So really here you can only derive from their symptoms. So they do have some characteristics of ADHD, such as not responding to the teacher, throwing tantrums. So these can be seen as like hyperactive activity. Though it is not common for people with ADHD to have tongue protrusion. So why would you have protruding tongue? And that's usually because you have an enlarged tongue, which would be a character of Down syndrome. And then making a clicking sound is really about developmental conditions. And I think what's most important here is developmentally, it took Sam a long time to learn to sit, walk, and toilet train. And these are not the symptoms you would have in people with ADHD. Though I do want to focus here that there are many symptoms that can overlap between conditions. So it's unfortunately common for people to be misdiagnosed, or sometimes, some symptoms may just be overlooked. So, and this is why it's important to always think about what are some other diagnoses possible. You really want to search all of your differentials. Another part that I have trouble with is this behavior was stigmatizing and disruptive. So our society is not that supportive sometimes to people with developmental conditions. And it's important for people to, raise awareness of these conditions. Okay, so before we talk about psychiatric conditions, I do want to talk very quickly about epilepsy. So epilepsy really, we know it is characterized by multiple seizures that cannot be explained by other complications, okay? So if you have like a traumatic brain injury, like if you're playing hockey and then you bump your head onto the hockey stick or something, or you fall, now that has a very clear cause, right? You have a brain injury. But if you have just seizures out of nowhere and you don't have other conditions, we call them epilepsy. So epilepsy has many different types. We can have petit mal, which is rapid blinking and then just staring into space. So it's kind of like the person is zoning out. Or we can have very grand seizures, such as falling, you have some muscle spasm, crying, and loss of consciousness. I'm actually gonna not show this video because this is a little bit disruptive. But there are videos of different types of seizures that you can see. Now, what's going on in the brain? So remember last time we talked about EKG, not EEG, electroencephalogram, where we can record electrical signals in the brain. So if you look here, before the onset, before the starting of a seizure, you can see they have fairly regular brain patterns, right? But during a brain seizure, what you see is highly disruptive, irregular, strong signals in the brain, talking about some, electrical problems. Now, the molecular mechanism behind that is not so clear, but there has been shown that there might be sodium channel issues in people with in the brain of people with epilepsy, in that their neurons are more active. So there may be less inhibition onto the neurons and there may be more excitation. So overall, their brain is just way more active as shown here. Okay, do we have any questions about developmental disorders or epilepsy? All right.
Nothing in the chat.
Awesome. So I'll very quickly talk about psychiatric conditions. So psychiatric conditions are mental disorders that affect the way we think and puts us at risk for disability, pain, or loss. So I want to focus on 3 big types of psychiatric conditions here: anxiety, mood disorders, and cognition related. So first I want to talk about anxiety disorders. So anxiety is the feeling of being on edge, or just you're always so alert, right? So in everyday scenario, it's helpful if our body knows there's a threat or we're preparing for an event. So it's okay to feel anxious before an exam, right? Or if you're walking down the street and there's suddenly like a tiger jumping at you, it's normal for you to feel the sense of threat because you want to always know how to react to that. However, it is not healthy for us to be in constant stress, right? I'm always so anxious. Or if our body is just so sensitive or reactive to stress, right? You see some people will get very easily startled by even the tiniest little things. So again, anxiety, you will see a really diverse array of symptoms. People may be shaky, may feel they're gonna faint, they will sweat a lot, their heartbeat's gonna go up. And anxiety really is the most common type of mental disorders here. So in anxiety, I do want to talk about the brain circuitry here. So first of all, it's important to know that different parts of the brain communicate with each other to form these little circuits. And really, when we talk about conditions, we want to see where in the circuit has it gone wrong. So in our brain, there's a part over here called the amygdala. The amygdala is important for fear processing. Whenever we get scared, our amygdala is going to be very active. And the amygdala sends these fear signal into this area called the prefrontal and anterior cingulate cortex. You don't have to remember the names, by the way, but this region basically assesses the fear, right? It evaluates it. How important is this fear? How strong is this fear signal? What should I do about it? So really, your amygdala is talking to the cingulate cortex, kind of like reinforcing this anxiety. At the same time, you have an even higher region that is in your prefrontal cortex that suppresses it, right? It say, hey, be logical, okay? You're gonna be rational here. There really isn't, a strong fear necessary. So this is, downturning this whole circuitry. So you would have what we call a feedback loop here, okay? But in the process of anxiety, what you would have is your amygdala is hyperactive. You're always sensing fear. You always think there's some fear going on. correspondingly, your downstream regulation is attenuated, which means your prefrontal cortex, even though it's saying, hey, be rational, is not saying that as strongly, so that you would always have your brain circuitry tuned towards fear.
Hey, were you done with were you at a slide transition? Or?
Yes. Yeah, I see there's a
Okay.
chat question.
Yeah, I thought, yeah, it's a really good question in the chat. So for those of you who can't see, Adriana asked, how can you help someone if they have an anxiety attack, which I think is a really good question.
Yeah, that is an awesome question. So there are a lot of, therapy skills that people can use. I believe one thing is called, well, there are several, but again, we're not doing therapy here, so take my words with a grain of salt. But what you can do, first of all, is to cope ahead, right? If you know you're going to be in a stressful scenario, you talk yourself through that. That has been shown to be effective. If you're in an active state of anxiety attack, research have shown, really lowering your body temperature is helpful, like splashing cold water to your face is helpful. If you're in a chronic state of anxiety attack, like you're so ever hypervigilant, you will want to talk to a psychiatrist for sure, and medication might be a good support. Okay. So that's with anxiety. We want to talk about OCD a little bit, obsessive compulsive disorder. So this affects about 1% of the population. It's really about uncontrollable and recurring thoughts. So we call these thoughts obsessions, right? But when these obsessions or when these thoughts become behavior, we call them compulsions. So repeated ritualistic behaviors. So one example would be, there's COVID going on. And if I have OCD, I might be thinking about, well, I need to make sure that I'm clean. I want to be clean and germ-free all the time. And that will be an obsession. If I do something about it, like if I wash my hands like every 10 seconds, or if I shower like 5 times every day, that's more like a compulsion, because you're trying to cope with your obsessions. There are other types of OCD, such as hoarding. There is a TV show on hoarders, if you know. There might be, obsessions, you're always tracking for harm. So one of the OCD-like behavior that I have is I always need to check that my door is locked when I leave the apartment. I need to, sometimes I would even walk back to my apartment just to make sure it's locked. So that can be seen as a mild version of OCD.
In many ways, Matthew is a typical 12-year-old. He loves video games, basketball, and his dog Maddie. But there is something different about Matthew. He describes it as an internal voice focused on his fears.
What's the name you gave it?
Mental convincer.
The mental convincer?
Yeah.
What was the voice saying?
What if I wanted to hurt myself or something like that, and then I started getting really nervous and I didn't know what to do, and then the thoughts just kept on rolling and rolling in my head.
Matthew has obsessive compulsive disorder, or pediatric OCD, a brain disorder in which obsessive thoughts lead to extreme anxiety and compulsive behavior trying to reduce that anxiety.
I used to have to keep my chair in and facing myself, or else I couldn't sleep. So when I'm going to sleep, it had to be like this, always. Okay,
so very quickly about Matthew's condition, remember that he talked that there's this, mental convincer in his head, right? That they're telling him that you have some thoughts, these thoughts are kind of just planted there. So that is very characteristic, very signature of obsessions. And then his compulsive behavior, one of them is to always make sure that his chair is put in a certain direction, right? You have to cope with those obsessions. Okay, moving on, we have panic disorders or phobia. So panic disorder and phobia are about sudden and unexpected bouts of intense and irrational fear, okay? And it's normal for us to be fearful about something like snakes or, accidents or blood sometimes. But if you have really strong and irrational fear going at it, then you might be having phobia. So the physical symptoms will be you're hyperventilating, you're breathing really fast and really hard, you feel like you're gonna faint, you sweat a lot, and your heart is racing. So what do we do to people with phobias or panic attacks? Well, one thing that is really helpful is actually exposure therapy, right? If you're so fearful about spiders, then it's been shown that if you are exposed to more spiders, you are actually more desensitized towards it. So we call that systematic desensitization. So I just want to show you a very quick study. In this case, researchers recruited people with phobia towards spiders, and then they show them images of spiders or neutral images that would not invoke their panic attack or phobia response, which are butterflies. So you would see here, you would expect that people really have strong ratings of fear towards spiders. However, after exposing to spiders for some time in exposure therapy, you see that ratings go down, right? So people are now desensitized toward this original phobia. And correspondingly, what happens in their brain? Well, you really see as they become more and more desensitized, meaning that they're more comfortable with the spider, this brain area in their prefrontal cortex lights up. So there is evidence showing that there is more control in their brain over their fear, right? So they're not always driven by this fear, but this time they can suppress that fear. And this is one of the evidence of how exposure therapy really changes your wiring in the brain. Okay, do you have questions about exposure therapy, phobias, anxiety disorders in general? All right. Okay, so we're actually going to skip PTSD for the interest of time because I want to talk about major depressive disorder quickly. So major depressive disorder is a result of genetic and environmental factors. It's very complicated. You know, people develop depression at different stages of their life. What people typically show or experience would be prolonged sadness and increased doubt, at the same time, decreased interest in oneself, environment, or future. So depression used to actually be called melancholy, where you would always be stuck in the state of sadness. Sometimes it is so strong that people develop suicidal ideations. At the same time, people have usually anhedonia. So anhedonia is a lack of motivation or lack of pleasure in doing things that are normally pleasurable to them. Like before depression, you will find, going out with friends is very fun and you want to, spend time with them, you want to eat food with them. But after you have depression, these are no longer fun to you. So treatment for depression usually involve selective serotonin reuptake inhibitors, or SSRIs, and therapy, including cognitive behavioral therapy. There's also dialectical behavioral therapy. So very quickly, and you don't actually have to know this too hard, but in our brain, there is a neurotransmitter called serotonin that its level, it's, if it's in a normal range, then it's actually helpful to combat some of these depressive symptoms, right? So depression is associated with lower level of serotonin. Now, the way SSRIs work is they keep serotonin in the synapse longer so they can provide their action longer, right? So they're not being recycled into the presynaptic neuron as frequently. I see.
We have several questions in the
Okay.
chat. The first one is there a way to prevent depression and can you grow out of depression?
Okay, so Adriana, that is an awesome question. There has been some initial studies about preventing depression. One of them is to screen people at risk for depression. If you have relatives, especially first-degree relatives who have depression, then you are considered to be at risk. Or if you have experienced trauma in the past, now trauma can be very diverse, right? If you have a traumatizing, like an accident, if you're in a car crash, if you have experienced like a natural disaster, there's actually studies showing that people who lived in areas affected by Katrina and Hurricane Irma, they have, greater risk for developing depression. So community resources such as talk groups or therapy groups can be helpful. And real depression sometimes is considered to be a long-term diagnosis. So, I guess growing out, you mean like managing it well. Now that is certainly possible with proper medication, therapy, or whatever treatment that is personalized to you, it is certainly manageable. Is depression genetic? That is an awesome question. there is a huge genetic underpinning into depression for sure. If you carry certain genes or certain alleles of the genes, you're considered to be more at risk. However, importantly, you can only say that in populations, right? You cannot just screen someone and say, hey, you have this gene, you're at risk, because that's not how specific our science in this field is. Can SSRIs cause hyperactivity? Good point. So SSRIs sometimes do carry side effects. Sometimes people would say it's actually more common to people to be drowsy and less energetic in everyday life. But sometimes, psychiatric medications provide this paradoxical effect where it kind of, it exacerbates your condition. So hyperactivity is a possible side effect. Okay. Last thing I want to talk about quickly is schizophrenia. So schizophrenia is different from anxiety or mood disorders in that it is a disorder of cognition. It has many causal factors, including nutrition problems, virus infection, genetics, trauma. So in schizophrenia, there are many conditions. It is sort of thinking, cognition, emotional behavior, social behavior, and many other things. So people studying schizophrenia usually talk about positive and negative symptoms. So positive or externalizing means the thing that you are directing towards other people. Wait, hold on, sorry. Positive means you have new additional symptoms like hallucination, like if you're seeing things that aren't actually there, if you're hearing voices that aren't actually there. So those are positive or add-on conditions. Negative means you have decreased activity in terms of things, such as you may have at the same time anhedonia. You have low pressure, you have low pleasure to things that are normally pleasurable. You're more introverted, you don't want to move. So it really is a mixed bag of conditions here. Treatments include antipsychotic medication, which dampen the response of dopamine. It's not very clear how dopamine, which is a neurotransmitter, works in schizophrenia, but antipsychotics have shown to be very effective. So psychosis basically is describe a condition where your perceived reality is different from the reality that is actually true. Like if you're hearing voices or seeing things, or if you're believing that someone is constantly trying to harm you when they're really just minding their own business. Okay, so those are everything I want to talk about psychiatric conditions. We weren't able to cover bipolar or PTSD, but they are less common amongst kids and adolescents. But I would have them posted in the videos. All right, so now let's talk about cognition. And I believe I have my volunteers to jump in.
Hello. So this next session is kind of about cognition, which is and more specifically memory and a little bit about speech. So next slide. So this is kind of a chart describing, well, what this slide calls the standard model of memory. So first it starts with a stimulus, which is what essentially your brain is inputting. So you are staring at this presentation right now, and odds are you're also seeing kind of other things that are going on around. That is a stimulus that your brain is taking in. And this first sort of hit of the stimulus is called sensory memory. And that's everything that comes at you at once. So everything you see in this presentation, everything that's going on around you, that's what sensory memory is. So, and then as it moves on to the next stage, interference occurs, which means that some of the memory is lost, aka forgetting. That just means that your brain is kind of dropping the unimportant stimuli because it's not necessary for functioning. So the parts of the stimuli that your brain is paying attention to carry on to working or short-term memory. And this lasts for generally a few minutes. This is also helped by rehearsal, where you and your brain kind of run through the memory over and over again a few times. I don't know if any of you are involved in theater. It's called rehearsal because like you rehearse a play or you rehearse a song, you're practicing it over and over again to remember it. And that's exactly what your brain is doing with certain working or short-term memories. But in the stage of short-term memory, again, the less important stuff is lost, interference, and forgetting. And the majority of this stuff that was rehearsed or deemed to be important enough for rehearsal is encoded into long-term memory, which means your brain stores it away for possible later use. And to touch on that point of later use, the sort of reverse direction of encoding is called retrieval, where your brain essentially retrieves a long-term memory that may be relevant to you at the time by pulling it back up into working memory so you think of it. Like, for example, say you're like studying math problems and you learn a method and that gets encoded into your long-term memory, but the day of the test comes and you need that memory right up front. So your brain retrieves that from long-term memory and puts it back in your working memory for use. And over time, some long-term memories can decay, which is essentially falls under the same umbrella of forgetting, but it's different than interference. There's a question in the chat: is memory loss a part of ADHD and dyslexia? Adrian, are you able to answer this one?
It's memory loss is not one of the signature issues. I would say in dyslexia, there might be some accompanying memory loss because the processing of language is less efficient. For ADHD, it's more likely that people with ADHD have decreased attention so that the encoding stage of memory may not be as effective.
Or potentially the attention stage as well, I believe, yeah. So I know I kind of just gave an example, between working memory and long-term memory, but here's sort of a whole example from the beginning. So for sensory memory, okay, say you want some pizza and you, Google the phone number for pizza and you see it. So you're hit with that immediately. Sensory memory is transient and it lasts for only really milliseconds. And then once you see that number and you want the pizza, it goes into working memory. When you're dialing, you repeat the number many times, or that's rehearsal, repeating it many times to keep it in your memory. Yes, and that rehearsal is what keeps the information active in short-term or working memory. And then that gets encoded into long-term memory. Now that you know the number, the next time you want pizza, you just dial it. And you can retrieve that information from long-term memory back to your short-term or working memory and dial that number again. And this is a sort of a diagram on the types of memory. So on the left, just to cover it quickly, that's short-term and working memory, or essentially the second stage after sensory. So, but when you go into encoding and long-term memory, there are several different types, which we will go into detail. So first, on the left of that, there's explicit or conscious memory. There's two types of that. There's episodic, which are like memories that generally like have an emotional connection. They're some sort of emotional connection to, maybe it might be strong, it might be mild, but they're events that happen to you. They're your experiences. Whereas semantic memory is general knowledge of the world. It's like what you read in a history textbook. They're not things that happen to you. There's things that happen that you know about from learning. And then on the other side, we have implicit or unconscious memory. And the two types of that are priming or procedural, I guess another word for most procedural memories would be muscle memory. I'll get into the specific example later, but think of procedural memory as muscle memory. Now, I did see a question in the chat before I move on.
There's a question.
So if you're remembering something, that memory is in your, yes, correct. It is retrieved from your long-term memory back into your working memory. What's priming? We are about to get to that really soon. In a couple slides. So first, explicit memory. Episodic, as I explained, it's something that happened to you. It's your memory, essentially. An example, I had chocolate ice cream yesterday and it was really good. Personal experience, you know it was good when you think about it, but other people can't feel your feelings about the chocolate ice cream. And semantic, again, something you would read in, for example, a history textbook, George Washington is the first president of the United States. That's knowledge you can share with other people. And when you think about it, a lot of this presentation will become a part of your semantic memory, hopefully, because it contains knowledge that you will share with other people. But your feelings about listening to this presentation, that's an episodic memory. Okay, so to answer whoever asked the question about priming. So priming is essentially when a stimulus, which is something that kind of, again, essentially comes at your brain, is influenced by something similar you remember. Like, for example, we'll do this activity here. On the left, so you have bread, juice, milk, and then this word you have to fill in a letter. Does anyone want to put in the chat what they think that that third letter is? Yeah, because it's bread, juice, milk, and soup are all consumable. They're all, I'll say consumables because they're technically not all food. So that, and do you want to try the one on the right? Yes, exactly. So yeah, it's an A, soap. It's examples of like things you would use when getting ready for bed or getting ready in the morning. You shower, towel, shampoo, wash your hair, and you have soap. So that's essentially what priming is, when your previous knowledge affects how you perceive a stimulus you're receiving or something that is coming at your brain. So your previous memories are having an impact on your, I guess, the new memories that you are formulating at the moment you're receiving the new signal.
Yeah, and just very quickly, Jane, so on the picture on the right, it's something that we would see before.
Yeah, go. Yeah, can you explain that? Because it's hard for me to see the picture.
Oh, yeah. So on the right, what you see is what we typically see before we enter the grocery store, right? You will see what's on sale. But this is actually a type of priming because this is really trying to unconsciously or subconsciously tell you that, hey, we have all of these things on sale, and you're more primed, you're more tuned to think about these stuff unconsciously when you are in the grocery store, and you'll be more likely to actually purchase these things. So priming is something that we would experience like almost in daily life. Yeah.
Thank you.
Yeah, go on, Jane.
Okay, so now going on to more types of implicit memories, procedural, which I mentioned as being like muscle memory. So an example I'm sure we can all relate to is walking. When you first started to walk, you really had to think about it and commit like the steps of walking to memory and think, oh, you move your muscles in a certain way and you take a step in a certain way. But now that you've done it so many times, it's become muscle memory. Your muscles know what to do, and you just kind of do it without really thinking about it. That's why it's called That's why it's called implicit, because it's not something you have to actively think about. Now, this slide is giving another example of another possibly procedural memory, driving. Driving is highly procedural. You can tell someone how to control the steering wheel or step on the brakes, but the whole action of driving cannot be verbally taught. One must actually experience it. And when you're first like learning to drive, you have to really think about what you're doing and think about the rules of the road, think about like, I guess, just the action of driving as a whole. But once you're like more experienced with driving, it just kind of comes naturally, in the sense that you don't have to think about every little action you're making in the car. It just becomes, again, a muscle memory. Oh, here's I guess a turn you got to make. You know how to turn without breaking it down into the individual parts and thinking about it. In the chat, so a muscle memory, procedural, implicit memory, the same thing. Essentially, yes. I mean, I can't think of any examples off the top of my head, but there might be there could be potentially like a cognitive procedural memory, like I guess addition, for example, could be a more cognitive procedural memory. You're not really using muscles for that. You're just kind of, that's more something that's happening in your head, like you're adding up 2 + 2, and you get to a certain point where you don't have to write it out, you just know it. But muscle memory would be a type of procedural memory it'd be essentially any procedural memory that involves you moving your body in essentially any way. So this is sort of an example of like an effect on memory. This is a case study with a patient, HM. So this patient had this is a pretty famous study of a patient who had severe epilepsy as a child, which we discussed earlier, what epilepsy is. So he had these really severe seizures. And in order to attempt to lessen or hopefully cure these seizures altogether, he had his bilateral hippocampi surgically removed. And the hippocampus is a part of the brain that is very central to storing memories. And this alleviated the seizures, but left him unable to retain memories. And we'll get into the specifics of that in the next couple slides. So to go on with this patient, HM had amnesia. There are two types of amnesia. There's retrograde amnesia, which essentially you can form new memories, but any memory lost before a certain brain trauma, whether it be an accident or in HM's, or not in HM's case, because this isn't, but like an accident or a surgery, if it is difficult to remember, if one cannot remember events before any sort of trauma to the brain, that is retrograde. The other type of amnesia, which HM had, is anterograde amnesia, which you can remember things that happened before the traumatic event, but you cannot retain new information and you cannot create new memories. So HM was unable to convert short-term memories into long-term memories after the operation. He could not remember he could not form semantic or episodic memories, but his body could remember, but his implicit memory was fine. His body could remember tasks, essentially muscle memory. There's a question in the chat. Are certain parts of the brain responsible for certain types of memory? There are other certain types of the brain that contribute to memory. The hippocampus is generally the part of the brain that you think of when you think of memory, but other parts of the brain sort of contribute to that. Like, yeah, because we will also get to certain parts of the brain that contribute to more muscle memory. And there's also the frontal lobe has a lot to do with sort of transporting memories to other parts of the brain. Is schizophrenia related to amnesia? I do not believe so. They're completely separate, because schizophrenia is a psychiatric disorder and amnesia is just essentially the loss of memory or inability to form new memories. So this is digging into more of the brain structure. So as I mentioned, the removal of the hippocampus caused the severe anterograde amnesia, which I mentioned was the ability to form new long-term memories, and temporally graded retrograde amnesia, which is the inability to recall recent long-term memories, but he could recall things that happened well before the surgery. And as I mentioned before, the hippocampus serves as a hub which links working memory and the long-term memories that are stored in other parts of your brain. So the hippocampus is important in the encoding of short-term memory to long-term memory and the retrieval of long-term memory into short-term memory. So I hope that answered your question about the hippocampus and memory. So I believe we already sort of touched on this, but working memory, yeah, but I know, yeah. So we have working memory, which is information from experience, as I mentioned on an earlier slide, but it wasn't on there. The prefrontal cortex is the first part of the brain that takes this memory in and then sends it back to the hippocampus for the encoding versus retrieval stage. Declarative memory is basically another way of saying semantic memory. It's recalling everyday facts. And episodic memory, as I mentioned, is personal experiences. And I also touched on the importance of the hippocampus in memory. Question to the person who asked me this question, is it okay for me to say this out loud? Okay, so the question was, could you kind of talk about the distinction between short-term and long-term? Is recent long-term memory not the same thing as short-term? So the distinction is short-term memory lasts, I think it's 5 to 7 minutes. It doesn't last very long. So something that happened to you an hour ago, that would already be in long-term memory. So yeah, short-term memory is just what you need to remember in the moment, and it's a shorter period of time than you would think. It's only really a few minutes. So what happened to you this morning, what you ate for breakfast, that would already be in your long-term memory.
Yeah, another really important aspect is for short-term or working memory to be active, you have to be consistently rehearsing it. You have to be repeating that information for it to be active. Now, if you have some information that you recall from an hour ago, but you were not actively trying to repeat it, that would mean that it's already committed to your long-term memory. It's just a recent long-term memory, but it's still long-term.
All right, so this is a bit on storing memories. So storing memories involves sort of increases in the synaptic and changes in the synaptic strength of the neurons. Adrian, did they talk about synapses last week?
Yes, yeah.
Okay, so essentially these synaptic connections have to be stronger, or cells that wire together, fire together. So if these brain cells are sort of encoding the specific memory, multiple will be firing at the same time, and they will have a sort of stronger grasp of the memory because the synaptic strength will be stronger. This ties into long-term potentation, which potentation essentially means just the strength, just making something more powerful. Potent means powerful. So potentation is essentially making this firing stronger. And this relates to the release of the neurotransmitter glutamate into the AMPA receptor. And the AMPA receptor modulates cell excitability, and excitability is generally the firing of certain type of specifically excitatory neurons, which essentially allow your brain to function, and it speeds your brain up instead of shutting it down, which is another type of firing. So this increase in firing allows for an easier storage of memory, an easier recall, allows for just a stronger memory. And this is essential for storing long-term memories, because with the more effective firing, more long-term memories can be stored, because it takes less effort to depolarize the cell or fire the neuron, which allows for an easier storage of the long-term memory. So now, okay, question. Are all neurons able to store memories? I do not believe so. It's just it really depends on the areas of the brain that relate to memory. Neurons in the areas of the brain that are connected to memory, those are the neurons that are active in memory storage and memory related actions in the brain. So now we are going to move on to language. So we sort of study the connection between language and the brain by looking at people who have lost speech and language abilities due to lesions, which is another way of saying brain damage. So two areas that are sort of crucial to the production and understanding of language are Broca's area and Wernicke's area, which are which are sort of two parts of the temporal lobe. So Broca's aphasia is the loss of speech production, and that would be damage to if one had damage to the left frontal lobe, which is where Broca's area is located, they would have difficulty producing speech or saying words, but they would be able to understand the words being spoken to them perfectly. Now, Wernicke's aphasia is damage to Wernicke's area, which is in the left temporal lobe, and that results in impaired speech comprehension, which means they can communicate just fine, but they have difficulty understanding the words spoken to them. And word deafness is damage to the superior temporal lobe, which is sort of the temporal lobe that's sort of higher in the brain, or in both the left and right hemispheres. And word deafness is the inability to comprehend auditory speech on any level. So yeah, I don't know if you want to play those videos, Adrian.
So first we're going to talk about, we're going to look at what Broca's aphasia is really about. This is also, again, called non-fluent aphasia. And as Jen was talking about, this is issue with speech production.
Years ago.
Okay.
And
what did you used to do?
Worked Autodesk, sales and worldwide, and very good. Yeah.
Okay. And who are you looking at over there?
So really here, oh, go ahead.
I was sorry. Yeah, I was going to say, as you can see, his speech is very sort of broken up, kind of incomprehensible. He has difficulty forming full sentences. It's difficulty communicating in speech, but you could tell that he could understand the questions he was being asked, and he was trying to answer them. He was just leaving words out because he wasn't able to form them. And then I also believe, oh wait, that was another question. I also, and then do we want to show the video on Wernicke's?
Yes. So quickly about Wernicke's aphasia, it is a problem with speech comprehension. Now, in terms of speech, it really presents itself by, the patient being very fluent, but what they're saying doesn't really make sense.
Hi, Byron. How are you?
I'm happy. Are you pretty? You look good.
What are you doing today?
We stayed with the water over here at the moment and talked with the people for them over there. They're diving for them at the moment. They'll save in the moment. He'll have water very soon for him. With luck for him.
So we're on a cruise and we're about to get to...
Yeah, so as you can see, he's speaking perfectly fluently. His words are clear and he's stringing together full sentences, but you can see the sentences aren't making too much sense, and he's also not responding to the questions in what seems like a answer that would make sense.
Okay. And now we'll be moving on to neurodegenerative diseases hosted by Neil.
Awesome. Thank you for that introduction. Slide, please. So the very first topic that we'll talk about in neurodegeneration is the definition of it. So it's categorized by the systematic and progressive destruction of the neurons within the brain. So this actually happens on two different levels, the cellular level and then the tissue level at a higher level. So on the cellular level, you're looking at the death of the neurons themselves due to oxidative stress. This could be from free radicals within the body system. Organelle dysfunction, for example, the endoplasmic reticulum stress or apoptosis or inflammation can also cause these processes. However, when you look on the actual tissue level, this presents itself in a reduction in size, also known as atrophy. This also leads to a lower integrity or connectivity in the white matter tracts. And then lastly, again, reduced myelination between the neurons, which again ties back to the lowered connectivity between these neurons. And again, this is not part of the normal healthy aging process. This is actually an atypical process, which would be disease-based. Slide, please. So you can take a look at this image down here to our right. So you can see comparing the left and the right. The left brain does have a lot of degeneration within it. Specifically, if you look at the temporal lobes on the right and left sides, in addition, the ventricles or the spaces within the brain are also looking abnormal as well. Slide, please. All right, so the first disease we'll talk about is Alzheimer's disease. So the kind of symptoms that might show up can really range based on the amount of time the person has been suffering from it. In the early stages, it presents itself in memory problems or maybe attention deficit or disorientation. But as you progress through this disease, it could actually go all the way to the point where that person actually has a lack of autonomy or really can't do anything for themselves or can't even recognize their family. So some of the causes of this disease include beta amyloid plaques, tau proteins, which actually essentially bunch up into neurofibrillary tangles. This actually happens mostly in the hippocampus and the cortex area of the brain. In addition, if you look at the picture on the right, these amyloid plaques are essentially bunching up around the synapses and causing them to erode, which actually impairs the neurotransmitter release from the synapses themselves. So a couple of treatments that we've identified is actually using cholinesterase inhibitors or NMDA receptor antagonists. So I don't know what level you guys might need to understand this for the brain being coming up. But at the basic level, the thing to understand is that Alzheimer's is a degenerative process, and acetylcholine is the main neurotransmitter responsible for this. Slide, please. All right, so the next one we'll talk about is ALS, also known as amyotrophic lateral sclerosis. So some of the symptoms that may present itself is there's not really an effect on cognition per se, but it's more on muscle weakness and muscle paralysis. So this can be caused by motor neuron degeneration, but this also has a genetic link. So if you look at the genes FTD-ALS and SOD1, FTD-ALS is actually familial based. This can be passed down through your lineage, as well as SOD1 can have gene mutations by itself. And if you have that mutation, then you do have a risk of developing ALS later. At the moment, unfortunately, we do not have a cure, but some of the research points towards potential gene silencing, almost like a computer program where you were to take a part of our DNA and essentially delete it or mute it in a way to hopefully prevent ALS. Slide, please. All right, so the next one we'll talk about is Huntington's disease. This is actually the most common hereditary brain disorder in the United States. Some of the symptoms might include mood swings or irritability, as well as involuntary jerking movements or decision making. So this is actually caused by the dominant HTT mutation located within chromosome 4. In addition, there's a sequence called CAG, the basic building blocks of the DNA, and this actually repeats anywhere between 36 to 120 times. That actually is what is the biggest cause of Huntington's disease. This all leads to eventual neuronal death within the basal ganglia. If you take a look at the picture on the right, you can see those areas marked by gray. That's actually the degeneration within the basal ganglia for Huntington's. Some of the treatments include gene silencing that we just talked about earlier. And there's new research coming out about tau biomarkers being able to track all these tau proteins that are causing all of these diseases. I do believe there was a question in the chat. I can go ahead and address that now. Adriana asked, how young can a person be diagnosed with Huntington's? So Adrian is probably the person to ask regarding this. He does a lot of psychology and psychiatry research. And Adrian, maybe you have a couple of wise words to add.
Yeah, so because it's really genetic, it can develop really at any time during a person's life course. But I believe the statistics shows it's mostly in their 30s or 40s for the jerky movements to emerge. That likely has to do with, just normal development of the basal ganglia that tend to decline around that time.
Yeah. Awesome. We have another one from Rebecca. Is Huntington's disease deadly? So in essence, it's not deadly in the way that we think if you compare it to, say, a heart attack. But the reason that it's a problem is because when our brains degenerate, essentially what happens is we lose the ability to function for ourselves. And when this disease gets to a point where one might not be able to take care of themselves, this might lead to life support or other kind of situations, to a point where you may not be the same person that you once were.
Yeah,
Great question.
And just a small addition to that, really, if the jerky movements are too severe, the person would be very prone to falling, which can be a huge health hazard.
Awesome. Thank you for that. Slide, please, Dan. Perfect. So now we'll talk about Parkinson's. So some of the symptoms that might categorize this disease are slow movements or muscle rigidity. So kind of the opposite of what we were just talking about, but you still have the shaking limbs. So some of the causes of this include the death of dopaminergic cells within the brain area called the substantia nigra pars compacta. In addition, Lewy body proteins, which are a buildup of these specific type of proteins within the brain, can also be a cause of Parkinson's. So some of the treatments that we have developed so far is we've identified a compound called L-DOPA, which actually relieves the motor symptoms of Parkinson's, as well as neurosurgeons can utilize deep brain stimulation within the basal ganglia in order to help treat Parkinson's to an extent. However, this actually has some interesting mood changes, apparently. Slide, please.
Oh, so we're actually just about to wrap up. So thank you, Neil. A funny story to share about L-DOPA. So L-DOPA is actually the premier medication. Okay, so I see there's another question about deep brain stimulation, which I'll briefly talk about. But L-DOPA was actually one of the first drugs that definitively showed it could improve symptoms in Parkinson's disease. It was actually discovered, I believe, in California, where some people were trying to use illicit substances and they actually synthesized them themselves. But unfortunately, the drugs that they made were not very pure, right? So they had impurities, and people who took those drugs eventually developed Parkinsonism, which is really symptoms you would see in Parkinson's disease. So researchers kind of like hooked onto that, and later one thing led to another. They discovered L-DOPA can actually relieve the symptoms. Deep brain stimulation is what's shown here. So you would implant like an electrode into the brain that inserts all the way to the substantia nigra, and then it's really chronically stimulating it to really inhibit some of these jerky tremors. It's really striking. And the patient have full control over that. They have a little remote that they can choose to either turn it on or turn it off. When they turn it on, you can see their shaking movements are actually very quickly just like resorting to normal. Okay, so overall, thank you so much for attending to today's tutorial. So remember, just a quick recap, we talk about developmental and psychiatric conditions, right? We have this bunch of terms that you might want to go over. Remember autism, ADHD, Down syndrome, dyslexia, epilepsy, major depression, schizophrenia, anxiety disorders. In cognition, Jane led us through the different types of memory. She also gave a lot of examples about, what is episodic memory, what is priming, what is procedural memory. Remember, the hippocampus is a hub between the working memory part and long-term memory, and it's so important that in the case of patient HM, we saw a bunch of amnesia problems. In terms of language, we learn about the Broca's area and the Wernicke's area and how damage to these areas lead to different types of aphasias. And lastly, Neil just went over neurodegenerative diseases. Remember, they're not a normal part of aging, but rather they represent this gradual process of neuronal loss or brain tissue loss. We talk about Alzheimer's disease, ALS, Huntington's disease, and Parkinson's disease. So just to wrap this up, I want to again quickly go over the reminders for you. Just remember to register at this website so that you can be up to date about all of our information. We'll also be shipping the Neuroscience at Home toolkits. One thing that I did forget to mention is if you're in the YES program with Ms. Mia Harsley, you don't have to do anything. We'll deliver them to the YES program. If you don't know what the YES program is, you probably don't apply to that, so we'll deliver it to your school or at an address that you prefer. We'll be in touch to tell you how to update your information if necessary. Studi has a question: how common are neurodegenerative diseases? I don't really have the numbers with me, but Neil or Jane, do you have an estimate?
No, I don't. I know each one would be different, but I don't remember the specific numbers.
Yeah.
Off the top. I want to say like, yeah, go ahead, Neil.
Sorry, again, I don't have those specific numbers on me, but I would say as the population ages in general, these kind of diseases tend to be more prevalent.
Yeah, and really another, sorry, no, I was just like, I will say, well, I don't remember the exact numbers. I know they are, as the years go on, they are trending upward, but that's more because I think our mean population, like age is, or like the mean lifespan, I should say, is increasing. So as that increases, the neurodegenerative disease rates will also increase.
And another part that I really want to share with everyone here is how important for us to address social inequity in our research. There is some research showing that different populations, different races are differentially susceptible to a lot of these conditions. And unfortunately, traditionally, biomedical research has focused on white population in the United States, but there has been recent really strong efforts in advancing our research into minority groups, African American populations, into immigrants, and even into clinical trials in other countries, so that we can get a more comprehensive picture on how all of these diseases affect virtually everyone. So there is research currently underway, but I would advocate that there's more social awareness needed to support that. Rebecca asked about ADHD. Where do medical professionals draw the line between normal hyperactivity in children and hyperactivity? That's a really good question. So in terms of a lot of these developmental or psychiatric conditions, what they do is they do like a scale. So clinically, the physician would carry like an assessment scale. They basically just tick off the items that apply to you. Like if you say, I feel myself fully energetic, and then they're going to ask you to rate that, to rate whether that's true on a Likert scale. So, from this is not true to this is moderately true to this is, completely true to me. And then they'll compile like a score. So that's really how quantitative is done. But as you can see, there may be issues, right? Because you may be just at the cutoff for ADHD, and then they will diagnose, well, you don't really have it. But is that true? Well, you are so close to it, so you may as well get some treatment for that. But overall, good question. It's still mostly done with scales. With psychiatric conditions, it's more tricky because it varies person by person and experience by experience. So that's more done via interviews, right? You talk to the physician and you come up with a diagnosis collectively. Okay, well, that's all for today, everyone. So thank you so much for attending. We'll be releasing the recording shortly, hopefully by this afternoon, and I'll be sending out a bunch of email reminders for you to recap the video and to make sure that you're registered. We'll also be in touch for the Neuroscience at Home toolkits. So remember, next Saturday at the same time, we have another tutorial where we're gonna focus less on content, but we're gonna be walking you through the kits. So stay tuned. And Neil and Jane, if you could just stay a little bit, that'd be perfect.
Thank you everyone for coming.
Thanks so much.